important factor. So I mentioned that this is our 20th challenge. So just to give you an indication of some of the challenges that we're solving, we're really delighted. This is our first health challenge, and we've been looking very closely at what our friends in the UK have been doing in the NHS, because they've been running, they call it SBRI in the UK. They like to be a little bit different, but they've been running these challenges for the past, I would say, 10 years, and they've got about 50 challenges up and running, from areas as diverse from cancer to obesity. So we've been looking at what they've been doing. You'll see some of the stats there, some of the savings that they've already seen through this process, and also, reducing waiting time, stays in hospitals. So a clear benefit for the patient, which is very important in SBIR, but also to the HSE, or the NHS in this case. So as I said, today's I suppose we're halfway through the kickoff for our first health challenge. If this one is successful, we hope to roll out further challenges in the future. But really, just to say that SBIR in health is all about the focus on preventative care, so it's to reduce the burden on the health systems. So I'm going to hand it over to Elaine from the CCIO's office in the HSE, who's just going to take you through this slide, and then I'll talk you through the process in a bit more detail.
Good morning, everyone. It's really great to see so many people here. First of all, I'm here on behalf of the Office of the CIO and eHealth Ireland, just to welcome you here and to thank you for coming. The reason we're involved is because there's a global crisis looming with an ageing population and rising chronic disease, especially the lifestyle type diseases. And with Sláinte Care and the eHealth Ireland, or the eHealth strategy for Ireland, I should say, we have a mandate to provide technology solutions to alleviate those problems and to help to solve them. So we're talking about keeping healthy people well, and that aligns with the Healthy Ireland strategy as well. So we again also recognise, as Marguerite said, that we have traditionally small businesses have had problems dealing with the HSE and getting involved and getting their solutions in to national nationwide usage. So we're delighted to be involved with this so that we can help in that line. And we're hoping for better patient outcomes and improve clinician experiences along with those technologies, and which will inevitably improve patient experience and lower costs, which is also important. So this challenge is about reducing the risk of women in a developing type 2 diabetes when they're pregnant, gestational diabetes, and also screening for diabetic foot disease in all patients that have diabetes. So with that, I'll hand you back over to Marguerite. Thank you very much.
Thanks, Elaine. Okay, so I just wanted to take you through the process, and just to say these slides will all be available afterwards on eTenders, or you can send us an email, so just in case you're wondering. So just to say, I suppose we're at this stage here today, or at the industry briefing. So we normally do a briefing session halfway through, once the invitation to tender has been up for about 4 weeks. Usually gives people time to digest it, and they know whether it's something that is of interest or not. So really, I suppose the goal of today is for you to walk away with a clear indication of the challenge, and to have an idea as to whether you will apply, or maybe you'll decide that it isn't for you. So we close on eTenders on the 22nd of February, and after that there's a 2-stage evaluation process. So there'll be an evaluation panel that's made up of the clinicians, members of the HSE, there'll be a couple of people from Enterprise Ireland, and then we also have some external stakeholders as well involved in that process. So we normally do, I'll take you through the dates in a second, but we're going to do a day for each sub-theme in the challenge. So we'll interview between 6 to 8 companies for each, but it all depends on the quality. So we may do less or we may do more, but that'll all depend on the applications that you all send through. So when we get to the end of that process, we decide how many companies we want to bring through to phase 1. Again, it's all down to the quality, so I can't say whether we'll have 2 or we'll have 8. But we have a funding pot, so we can be quite flexible with that. So if you are awarded onto phase 1, what is phase 1? It's a technical feasibility study. So really, you know, what we want you to get out of phase 1 is to have, I suppose, to scope out the problem in more detail. You'll have close interaction, you know, through points of contact with the HSE, so that at the end of phase 1, you'll come back in to present your findings. And really what we want you to tell us is, this is what our research indicated in problem A or problem B, and this is what my company is proposing to, you know, to develop to solve that problem. So then we take a smaller number of companies through to phase 2, and that's when things get really interesting. There's more money involved for the companies, and that's essentially where you co-design a solution with the challenge owners in the HSE. So it's usually, phase 1 is between 3 to 5 months. Phase 2, I would say, is normally 6 months, but sometimes it can run into 8 months. So at the end of phase 2, then you come back and you present, you know, your solutions, what you've developed. We also like to see a commercialization plan. You know, that's kind of where Enterprise Ireland, you know, like to come in as well. And the idea is that if the HSE see real value in the quality solutions that have been developed, we can then, you know, consider going to an open procurement process. But just to say, this is, you know, a year and a half down the line, but just to give you a sense of ultimately where you want to go. But just in cases where we have had challenge owners that for some reason haven't procured at the end, we have had companies that have managed to sell their products into other public sector bodies. So there is I suppose, a commercialization path as you go through the challenge. So just to reiterate, the budget is 200k, a bit of a difference, but that is our starting budget. So SBIR is a very flexible process. So as I said, if we see a lot of really good quality solutions coming through in phase 1, then Enterprise Ireland and the HSE will reevaluate, and we may be able to extend that budget into phase 2. But as I said, the maximum amount that we will give each company in phase 1 is 20k. We normally give every company in phase 1 the same amount, just to be fair. But for phase 2, if you're successful in getting through, you have to put together a very detailed proposal in terms of costing. So what we give to one company may not be what we give to another company. But for phase 1, it's a 20k contract all inclusive. So as I said, we close on the 22nd of February. So hopefully your applications will start coming in the next couple of weeks. Dates for your diary. So we're going to conclude the evaluation process by within early March, but the 2 dates for your diary are the 13th and the 15th of March. So the 13th of March, we're going to do the evaluations for the GDM part of the challenge, which Fidelma will present to you shortly. So that's going to take place at a venue to be confirmed, but it will be in Cork City. And then on the 15th of March, we have our diabetic foot ulcer challenge interviews. So that will take place in Dublin. Now, some companies have been asking me, can I apply to both challenges? You absolutely can. We do ask that you send in a separate, if you are proposing solutions for both parts of the challenge, because they are quite different, and to help us in the evaluation process, you put them into separate applications. So, and just to say that you probably won't get a notification about your interview time until the week before. So it's just really important to kind of have those dates kind of penciled in at this point, because we do have a quite a tight turnaround. And yeah, as I said, invites to interview will be sent the week of the 4th of March. So I think that's all from me, but we'll do a Q&A at the end of the session, and we'll answer any questions. So just to say, this is a very transparent process. So any questions that you ask today, we will be putting the answer up on e-tenders for the benefit of anybody who couldn't be here. And if you think of questions after today that you didn't ask, please post them on e-tenders. If you email SBIR Ireland, we'll still get you to put them on e-tenders, because we want to make sure that if you get an answer to a question, that all the other companies get the benefit of that response. Please follow us on Twitter so that you can keep in touch in terms of other challenges. And as I said, I'm here afterwards for Q&A in any case, but this is probably what you're actually here to hear about. So I'm going to hand it over to Professor Fidelma Dunn, who's going to take you through the GDM challenge. Thank you.
Okay, thank you. So good morning, ladies and gentlemen. Thank you for coming to maybe look at the skill set you have and see if the skill set could answer some of these difficult questions that we have in delivering healthcare to populations and subpopulations with diabetes. So I'm here representing a subpopulation of patients with diabetes. These are women who develop diabetes in pregnancy, and we call that gestational diabetes. And I'm here with my colleagues, Dr. Yvonne Finn and Miss Louise Carmody, and we're all around to answer any questions at the end in the Q&A session. So gestational diabetes is a common problem now, and it's the most common medical condition that we see in pregnancy. And what we want to do is to reduce the proportion of women who've had gestational diabetes going on to develop either pre-diabetes or type 2 diabetes 5 years after their pregnancy that was complicated by gestational diabetes. And we've broken it down into both pre-diabetes and type 2 diabetes, because if you develop pre-diabetes, about 90% of women with pre-diabetes will go on to develop diabetes. So pre-diabetes is like an early form of type 2 diabetes. And at each stage of the process, there's great potential to intervene to reduce the risk of going on to develop either one or other of these. So some of the key facts about gestational diabetes. Well, the first is a definition. So gestational diabetes is a diabetes that first presents in pregnancy. So you start pregnancy and you're perfectly normal, and for a number of reasons you get screened for diabetes, and you either have or you don't have the condition when you're screened. So internationally, about 17.8% of pregnancies worldwide are affected by gestational diabetes. This ranges from a low prevalence of about 9% up to a high prevalence of 25%. And the high prevalence is found in countries where there's a high background rate of type 2 diabetes. So in Ireland, we know that our population is somewhere in the middle. So about 12% of women who enter pregnancy develop gestational diabetes. And it's important in pregnancy because the pregnancy outcome for the mother and the infant is not as good if you have gestational diabetes than if you remain with normal glucose tolerance during pregnancy. For the point of view of this challenge, GDM increases the risk of future diabetes, and it's estimated from the international literature that this is about 50% in the 10 years following gestational diabetes. So it's a very high risk group who will develop type 2 diabetes. And when we look at what are the numbers in Ireland, well, on average, we have about 60,000 deliveries, on average, give or take a few thousand every year, and 12% will develop gestational diabetes. So that means we have 7,200 women each year who have gestational diabetes. And based on a 50% risk of going on to develop type 2 diabetes, that means that each year we potentially have 3,600 new cases in this population of type 2 diabetes or pre-diabetes. So if you look at that on the other flip of the coin, this is a group of people who are usually very highly motivated, and if we could continue to be in contact with them after their pregnancy with gestational diabetes, I think there's a real potential here to prevent disease and keep this population of young women very healthy. And we know from, again, international work that if you have healthy women running families, you generally have healthy families, and then you have less diabetes in the offspring of that family. So it's a really important challenge. So currently, what do we do? Well, during pregnancy, we have a really good handle on gestational diabetes. And women are looked after both by primary care and by secondary care. And generally they would come to primary care every 2 weeks and secondary care every 2 weeks. So there's lots of interactions between healthcare professionals and the woman during pregnancy. And during that time, there's a lot of motivational training of them, there's a lot of education, and there's a lot of input. And if we could harness what we're putting in during the pregnancy at these very frequent intervals, and continue to give that back to women after pregnancy, I think we would have a great chance of reducing diabetes. Now, after the pregnancy that the woman has had gestational diabetes, all those women are invited to come back for a re-screen to see if they have gone back to normal or continue to have a sugar problem after the pregnancy. And that usually happens at 12 weeks post-delivery, and it can happen either in primary or secondary care. And that is the first post-pregnancy interaction with the women. And for most women, this is the only interaction after pregnancy. Now, internationally, only about 50% of women come back to have that test. We do a little better here in the West, we're up to 75%, but we're missing a lot of women even for that first interaction. There's after that first interaction, then there's minimal follow-up for these women who are at high risk of diabetes. So anything after that is ad hoc, hit and miss. There's nothing defined. These women don't come back to secondary care, and they certainly don't go to primary care. And so the consequences of this is that the majority of these women receive no intervention to try and prevent diabetes. So we ask the questions then, what if women with prior gestational diabetes could understand and self-assess the risk of future diabetes periodically? So if they had some tool where they could say, I wonder what my risk is this year, would it motivate those women to do something to reduce that risk? If we had something whereby these women could monitor their risk and kind of motivate themselves for lifestyle behavioural changes that might decrease the risk of going on to develop diabetes. If we could continue with healthy life choices for these women for the first 5 years post the index pregnancy, we would certainly reduce a lot of diabetes. If we could, in some way through a technological solution, make sure that these women receive the appropriate interventions in terms of education and lifestyle. And if we could then also make sure that the women at very highest risk get the interventions from the healthcare professionals at a timely fashion. So if we look at where we are currently, during pregnancy, I think we have a very good handle on what we do. Women are generally seen every 2 weeks by either a primary care physician or a secondary care physician, and they come to the antenatal diabetes service in the hospital, or they go to their GP in the community. But after pregnancy, this is where we fall down. So we know that these are the defined periods of time where women might have an interaction with the health professional after pregnancy. So their first visit with the GP is usually at 6 weeks, and that's for a general check of the baby and of the mother. And the public health nurse usually follows up babies for a number of days following discharge for health checks. Then we have the defined repeat test for diabetes, which is the glucose tolerance test. That happens at about 12 weeks, either in primary or secondary care. But again, we're only getting at best about a 50% uptake around the country. And then this area here, post-GDM, where we have ongoing risk assessment, monitoring, education support and follow-up, we have zero in that space. So this is the area that we would like you to concentrate on to see if we could come up with a technological solution by which we can deliver supports and education to these women, keep in touch with these women, but try and have the very high risk women coming back to see the health professionals rather than the whole group. So some women who may take on the challenge of preventing diabetes in themselves will be motivated, they'll follow an educational plan, they'll introduce lifestyle, and they will limit their progress to diabetes. But some people just aren't able to do that and need to have constant or updates with health professionals to try and prevent it. So thank you. I'm around to answer any questions.
Thank you very much, Fidelma, for that comprehensive overview. We're going to move on to our second sub-theme challenge, which is around the diabetic foot ulcer. So I'm going to ask Professor Sean Deneen to address the audience.
Thanks very much, Marguerite, and thanks to you all for coming and showing interest in this opportunity. So I'm a diabetes doctor. I deal with the complex diabetic foot. This challenge is framed around trying to help us as a health service to tackle this problem with new technology and with some innovation. So a bit like Fidelma, I'm really delighted to be here. I really hope this is successful. I know it's down to a partnership, but we really do need some new ways of thinking and new ways of working with yourselves. I was struck by Barry's comments and how our languages are so different. I spent the weekend on call for medicine and CSF, which is a startup fund, is that right, Barry? Yeah, very different thing to me this weekend. Trying to frame this challenge for you, and I realize there are people in the audience who know quite a lot about diabetes, but I'm sure there are people who don't. We have become accustomed to an unhealthy lifestyle. Two main problems: we have easy access to high-fat food, and we are a lot more sedentary than our parents and certainly our grandparents. And this is a global phenomenon. This applies to people living with or at risk for type 2 diabetes, not type 1. But type 2 diabetes and obesity is now being talked about as a pandemic. There are aspects of the pandemic that we have not yet begun to recognize or realize. So type 2 diabetes, when I was in medical school, was a condition that we saw in people in their 50s, 60s, and 70s. Now we're seeing it in people in their 20s and 30s. And there are youth in inner city America who are developing type 2 diabetes in their teens. And they will have it for 20 years and still be very young. So the phase of the pandemic that we haven't yet recognized or realized is this early onset of complications. So really for us, we need to address our unhealthy lifestyle. That's an issue, and Fidelma's challenge is probably tied into that space. But we also need to think differently about the challenge of recognizing and treating the complications of diabetes, because they are going to happen. So with that in mind, we have this stairway to amputation, or this progression from not having diabetes down here, having diabetes, and then developing what we call the one microvascular complication of diabetes, which is neuropathy. So affecting the peripheral nerves. I can feel that this podium is wooden, or I can feel that it's not rough, it's soft, because the peripheral nerves in my fingers are working. If I put on tight-fitting shoes, my feet will tell my brain, because the peripheral nerves in my feet are working. One of the ways that diabetes can affect a person is that you can lose that ability to protect your feet. And we call that peripheral neuropathy. That can, in some people, then lead to a break in the skin, what we call a foot ulcer. And if that's not managed properly, or if it's combined with poor circulation, which does often happen in people with diabetes, then you're into foot ulceration, not healing, and so on. And this limb loss, just like vision loss or loss of kidney function, is a very frightening thing. And I try not to frighten people, but as a nation, as a health service, we need to be aware that this is happening. This is happening in Ireland, and it's preventable. So what we need to do is help people to recognize that they're at risk, and then tailor our treatment or our approaches to them based on their risk status. So that's how this looks. The person, and this is not meant to frighten or exaggerate. The hobnail boot with the nail sticking through it and the farmer wearing it for a weekend is a reality. We're talking about loss of sensation to that degree. And then foot ulceration, again, is often, in its early phases, reversible, but can get to a point where it becomes more difficult to reverse. So Lorna Hurley, who's part of the team that put this diabetic foot challenge together, led this West of Ireland diabetes study published a few years ago now, where we just looked at a relatively small cohort of our patients in the West of Ireland in about 12 or 15 practices. We screened them for diabetic foot problems, and we followed them for about 18 months. And what we found was about 2/3 of them were at low risk. They had no neuropathy, they had no vascular disease, they would be brought back in a year. About 25% of them were at risk, so they had either neuropathy or some impairment of their circulation, and then 11% were high risk based on prior ulceration or having both of the major risk factors. And in this relatively small cohort of patients, relatively small short duration of follow-up, we had about 18 foot ulcers and about 2 transmetatarsal amputations. So it's happening in our area. And the key to impacting on it is helping people to understand their risk, and tailoring the follow-up to that risk. So, whoops. I thought I had another couple of slides. I'll do it without the slides. So in 2013, Ireland, our HSE, introduced diabetic retina screen. You're probably familiar with it. And in about 120 screening centres around Ireland right now, people have digital technology applied to their diabetes. They have screening done for microvascular complications in the back of the eye. A retinal photograph is taken. And that is graded, and based on the grading, they're assigned a risk status. They're either brought back in a year, they're referred immediately, a small group for eye clinic and treatment, or they're in that middle ground. This is the exact same in the diabetic foot, but we do not have population-wide screening like retina screen. So retina screen is a wonderful example of public health and population screening happening. The National Screening Service is under the cosh at the moment because of all the controversy, but it is a wonderful example of doing something at a population level. And that's what we need, in my opinion, in the diabetic foot. So the challenge to yourselves is to try to come up with some technology or some solution that might enable us to do that easier. Right now, we have to, in our general practices around the country, we expect our GPs and practice nurses to take off the shoes and socks, use what's called a monofilament and a tuning fork to measure, sensation, to quantify sensation. And our sense is that it's not happening. It's certainly not happening at a population level. It's cumbersome. We hope it will happen, and it needs to. But we hope you agree, that we can probably do better with a technological approach or a technological solution. Okay? Thanks.
Thanks, Sean, and apologies, there were a couple of slides there missing, but what we'll do is we'll get the final version put up on our website and on eTenders, so you'll have the full presentation to go. So we might, we might start taking questions. Ciara, you might get the microphone here so that we can... So just to say, if you have any questions around, is my proposed solution potentially a fit, I'd probably refrain from asking those questions to the wider audience. Really what we want companies to do is to go back to the invitation to tender, not meaning to put it back on you, but really you are, I suppose, the experts in terms of the innovations, the technology. So if you feel, based on what you've heard today, that your solution is a fit, then we would encourage you to put in an application. But if you've got any specific follow-up questions, we can certainly deal with them. So does anybody have a question to kick it off? Yep.
Declan McFadden, I'm living in Singapore. Just a quick question to Professor Deneen. Is there a direct correlation between a poor retinal screen and the neuropathy, foot neuropathy?
So if I understand the question, is there a connection between retinopathy, the presence of retinopathy and foot.
Is there a high correlation between that and foot?
There's probably a higher correlation between the presence of retinopathy and kidney, what we call nephropathy, diabetes changing the kidney. But in general, people who develop one microvascular complication often have others, is the way I would frame it. I mean, so it's not as strong, like if it were, then the retina screen might work for the foot screen, but we have to screen separately. Yeah.
Thank you. A question for Professor Dunn. The correlation between obesity and overweight in these ladies, these 12% of ladies?
Oh, yes. So, gestational diabetes is more common in people who are obese and overweight. And at the moment, about a third of the activated population is obese, and about another 20% are overweight. So about 58% in total will have a BMI of over the age of 25. But we still do get gestational diabetes in people with a BMI of less than 25. So, for example, we could be nice and thin and trim, which would have a very strong family history of type 2 diabetes. We're still at risk of gestational diabetes. But a significant burden is in the obese and overweight people.
Thank you very much.
It's Joe from Telecam Labs. So how in phase 1, right? So is there any support from a clinical side, like to validate the technology solution?
So your question is there any clinical support to the companies? No, so we usually in this SBIR process say to the companies that if you are looking for your clinical inputs, that you source them yourselves, you source collaborators yourselves, but throughout this process you will have access to the clinicians, to the data that you need to undertake the phase 1, but no, we don't organise for outside clinical or collaboration support.
Okay, so there's some support, basically, there's some connections you can provide, basically, but you don't actively provide any. So
no, we don't, because we have to be very transparent and fair to every company that's applying. But if you get through into phase 1, you will all, whether there's 2 or 4 companies, you'll all get the same information, you'll all get the same access to the data within the HSE, and you will get access to the clinicians through a point of contact that we designate.
Yeah, what if the solution that there's no, so what if there's the solution required data that is not present in the current database, but is potentially can be very useful?
Well, we'd have to have a chat between yourself and the clinicians about what we would do in that case. Normally, in terms of phase 1, the data that you need is available, but we'd probably need to talk to you individually and bring the clinicians in if that was the case.
Okay, thank you.
Hi, I'm Sarah Burke from InfoCare. My question is kind of for both of our professors today. What kind of uptake or engagement have you seen in your patients with technology to date? And how are they using technology at present to manage their conditions?
I would say that there are lots of apps and online tools available for people living with diabetes. In recent years, we've had major advances moving away from blood glucose monitoring requiring a drop of blood from the fingertip to what's called flash glucose monitoring, probably the biggest breakthrough. People living with type 1 diabetes now have the option of using a continuous subcutaneous insulin infusion pump or an insulin pump. So there are examples of people embracing technology to live better with their diabetes. In the area that I work in the diabetic foot, we have seen some examples of technology being applied. There's a watch that was developed by technology people in the States, which helps with sensors in the footwear, helps patients to monitor pressure and report to them if they're overdoing it, in terms of pressure points on their foot. Pressure is a huge part of the problem. in the diabetic foot. It's lack of awareness of it, and it's so I think there are examples of it probably also in pregnancy or GDM, but I think we need more.
So I would say in the population that I work with, there's probably 100% coverage with mobile phones, and anything that's accessible or downloadable on a mobile phone that interacts with the patients, they will be using them. The patients, certainly in Galway, have worked with us on developing some technical solutions and developing apps in the past, so they're very engaged in the space. But when you talk to them in the clinical setting, they will always tell you about they've been on Facebook, they're on Twitter, they're on, an app for this, and so there's an app for obesity, there's an app for counting your calories, there's an app for the type of food, there's an app for the glycemic index of food. So there's lots of that available, and I would say they're all accessing it. But a lot of those are not interactive with the patient. So I think the technologies need to have more interaction. Yeah.
Hi, Tomas Ler, an endocrinologist, RADA. A few questions. One is, are you looking for a device? Are you looking for a software solution? Are you agnostic?
We're looking for everything and anything. So this process doesn't specify any particular type of solution. So we're putting it out to you, to the marketplace, to come back. So it could be a device, could be an app, could be, something that's partly in development, something that needs to be developed from scratch. That's completely open.
And as a follow-on, is there a scoring sheet for each of the applications that you can share with us?
Yeah, so if you go on to e-tenders, the invitation to tender document, it's about 25 pages long. You'll see the how we score applicants. So it's across 10 key areas, from innovation to the team to potential commerciability of the proposed solution. So there's 10 key areas that we score each applicant on. So you'll see them all there. If you've got any problems finding it, just send us an email.
Thank you.
Hi, my name is Grania Flynn and I'm a diabetes patient advocate, and I just came along today because curiosity just was killing me. I just want to add to that lady's comment about, is there an uptake of technology? I'm a walk-in medtech experiment. Now I do have type 1 diabetes, but I would like to just point out that the technology has to work for us. It can't make our life worse. It can't be extremely burdensome. If it is extremely burdensome, the only way we're going to use it is if it's magic, if it's a miracle. And that's the reason why I use an insulin pump. I use a continuous glucose monitor, and I'm actually exploring other DIY medtech solutions for my diabetes. So if it works, if it doesn't make our lives worse, then yeah, we're all in.
And I don't want to speak for Fidelma, but I know that, mothers of young children are busy with other things. It has to fit into their lives. And likewise, the diabetic foot patient, the problem is that they don't recognize it as a problem a lot of the time. So this has to be something that nudges them or gets them to recognize the risk and the condition.
So I just have a question on, two questions actually. One is, how developed ideas do you think you need at this point, based on the fact that there's 2 phases to the project? And also, would you accept applications from a consortium or a group of companies?
I can take those. So in terms of your last question, absolutely. We would highly encourage collaboration, and that's the beauty of these kind of events. Companies kind of with similar ideas or different solutions to the same problem can come together. So absolutely, but just make sure that there's only one lead company that's on the application. Can you repeat your first question?
Sorry, yeah. So at what stage of development do you think the technology or the solution needs to be at, based on the fact that there's 2 phases to the project? Are you looking for quite well developed, or is there some leeway for future developments take place?
Yeah, no, absolutely. We don't specify, but there has to be an element of future development. So some companies apply and they have something that they've been tinkering away with, but in order to progress that, they need to start testing it and they need to do further work. What we don't want in this project is companies that have fully developed products that they're just going to say, here, trial that. There has to be an element of, it's R&D, so there has to be an element of development. So there probably isn't really an answer to your question, but we've had companies that have literally just had an idea and have won through to phase 1, and we've also had companies that have been working away at something for a little while, but they just needed to get that anchor, I suppose, challenge owner or reference customer. So it could be at any stage, as long as it's not on the too developed side of things. Thanks.
Hi, my name is Conor Curley. I'm a doctor of nutrition. Just wondering if non-tech solutions are invited as well.
Yes, absolutely. Yes. So I know we've talked a lot about technology. The kinds of companies that tend to win SBIR challenges are technology, because that's the nature. But no, absolutely, it's a blanket, it's innovation, so it doesn't necessarily have to be a technological solution. Thank you for clarifying that, actually. Any other burning questions? Oh, yeah.
Hi, thanks very much. Christina Pertil is my name. Question for Professor Dineen. You mentioned that the retinal eye screening, you gave that as an example of a successful program. I was just wondering what made that program successful and what are some of the key takings, I guess.
Really good question. Yeah, and my feeling is that in chronic disease, the piece of the puzzle that we sometimes forget about is the public health perspective, the whole population. So I work in a hospital. Several of us here work in hospitals. We tend to think of the hospital trolley weights or what the main metric. Out in the community, we're working with I don't know what kind of metrics, but it's CHOs, community health organizations, and hospital groups. The population perspective is what I think Retina Screen has really delivered on. They are interested in knowing about everybody living with diabetes in Ireland. And retinal screening in other jurisdictions has impacted on vision loss from diabetes because they capture everybody. Now, of course, they don't have 100% capture, but they're at about 70% right now of the people that they're aware of. So my take on it is that we're at the coalface over in Merlin Park delivering a diabetic foot clinic. We have to go upstream, is that the right analogy? To where it begins, and we have to identify those at risk. So Retina Screen does that really, really well and refers appropriately when stuff starts to happen.
I would also say with Retinal Screen, it's very flexible for the patient, and the screening happens very close to where the patient lives. So the patient is the centre of the screening and the technology is taken to the patient. And I think that's a really important message for any of the solutions. And then the screening programme almost triages people into a solution for them based on the risk at the time the photograph is taken.
Professor Dunn, the Health Links programme initiated between primary care and secondary care was an online platform for communication and referral basis. How does that work with the pregnancy, the dual care, the primary care and the obstetric care? Is that a bilateral communication process?
I don't think we use that I don't think we use that currently in the way we deliver care. So the way the programme runs currently is a woman is pregnant, she goes to the GP confirms she's pregnant, refers the patient into the hospital. They come for their first antenatal visit. At that antenatal visit, a midwife does a risk assessment and decides, does the patient fall into the risk categories for diabetes? Okay. If that person does, then they have a screening test booked at about week 24. If the screening test is positive, they then come into the diabetes clinical service. Okay. When they come to the diabetes clinical service, then we grade their risk, and if we deem them lowish risk on the risk system that we have, they would generally come back every 4 weeks.
Yes.
If we think that they're a higher risk, they come back every 2 weeks. If they're coming back every 4 weeks, we instruct them to go to the GP in a 2-weekly interval.
Okay.
But it seems to be very much initiated by the hospital to the general practitioners rather than the other way. Now, the problem when the woman delivers is nobody recognises that the person is at risk. Nobody recognises that they may actually have a disease state now, because the return for the 12-week test is ad hoc, and we don't systematically around the country follow up each woman to ask the question, did that person come back for a screen? The primary care physicians don't see this group of women as in their domain because they haven't already developed a disease, and their contracts are linked to giving services to people who are sick, not preventing diseases in people who are at high risk. So that's where one of the biggest drawbacks, I think, is for delivering care in a community setting to these women.
I might add a clarification in terms of that. I think one of the reasons that maybe the Health Links project isn't so connected in with the combined care piece is that the combined care pathways and structures were very much well established long before Health Links came on. So I think it kind of it's there, it works. It hasn't been translated into the IT infrastructure. So.
They're bursting with a few questions. Sean, Professor Deneen, is there a path of no return on the stairway to amputation? Is it at the vascular stage, or is it at the neuropathy stage, or is it still a multifactorial and nobody knows?
I mean, by the time I get to see them, Dave, it's you know, the foot is complex, and there's usually more, you know, neuropathy, there's vascular, there's infection often in the mix. Most patients, the journey begins with loss of sensation. Ischemia, so lack of blood supply, is often a contributor to poor healing, for example. And it can lead to ulceration, but less commonly. Neuropathy, loss of feeling is the big thing. As our population is aging, interestingly, you know, we're probably seeing more neuroischemic, a bit of both, if you will, at presentation. But you know, the principle on which foot screening is based really is identifying neuropathy, because the patient won't complain. You know, they are silent, these patients with neuropathy.
Is the loss of vibration sense vital?
So I mean, there are different sizes of nerve fibers and different types of neuropathy. Small fiber, large fiber neuropathy. The monofilament and the tuning fork attempt, I think, to capture a bit of both. The biggest thing about them, though, is that it's as simple as it gets. I mean, there's more sophisticated ways of checking for neuropathy, but it can't be really done routinely, you know. So the monofilament, which is a piece of nylon, and the tuning fork, which the conductor of the orchestra uses, you know, most GP surgeries, most doctors' offices would have those.
Thank you. Question to Professor Dunn. Is there a register now and present for the women who develop diabetes for them to be easily tracked?
No, there's no national register. We have a regional register, and that's very helpful for us tracking patients, and that's where our administrator can get our post-pregnancy screening up to 74%. But we were as bad as international standards before we had that. But ideally what we do need, I think, is a national registry first of people who have this condition. And from the registry, then we could develop a call and recall system, and attached to that call and recall system, we might have educational or lifestyle intervention.
Right. So there's no, I mean, the rest of the regions don't want to adopt what's already out.
Yeah, I mean, it does take a little bit of resource. We were very lucky. We got some funding from the Health Research Board to establish all that back in 2006. But I mean, it's not something you can do on your own alongside doing your regular day job. Sure. You do need a little bit of intervention, a little bit of money.
Last question to Marguerite. Because it's small business and innovation and research, there's quite a bit of numbers given for the insurance requirement. So, could you elaborate a little bit more? Because normally when you do research in a university setting, you just tend to have a public liability insurance, whereas here you have a lot more in it.
So just in relation to that, there probably is a lot more in it, but because it's a two-phase process and the contract will likely be going on for 1.5 years, that's the reason that the public authorities look for that. But what I will say is we've never had a case of a company coming to us saying that the requirements have actually been prohibitive in terms of them applying. But if you have any concerns or any specific questions, once you kind of consider the criteria, just please come back to us and we can talk in a bit more detail. We had a couple of questions in from our Skype colleagues. This one is in from PJ in Educate for Health. So he wants to know, in relation to the collaboration or consortia, do all the members of the collaboration need to be Irish-based companies or organisations? They don't, because SBIR goes out across the EU as long as all of the parties have an EU registered address or presence. There's no problem there. We've got a question in here from Tanya Mulcahy in the Health Innovation Hub. This is a question for Fidelma. Are there biomarkers for GDM? Is it understood why some women get it and why some don't? Does it depend on diet and lifestyle before pregnancy or some other biological factor?
So I think gestational diabetes is pretty well understood. People get it because they have a combination of a deficiency of insulin and a resistance to the insulin that's being produced by the body. People who are more insulin resistant tend to be on the overweight, obese category. People who are more insulin deficient tend to have a lower BMI. The current diagnosis of GDM is very cumbersome because we have to use a glucose tolerance test. And we're currently working with some collaborators in the States looking at new biomarkers that we may be able to use instead of a glucose tolerance test. Now, if those biomarkers prove to be useful to diagnose gestational diabetes, then I think those biomarkers would also be useful for the follow-up of these women after pregnancy. And that would be a simple one-stop blood test, non-fasting, any time of the day, whereas the glucose tolerance test at the moment is both cumbersome for the patient and cumbersome for the process of delivering that test to them.
Thank you very much. And we have another couple of questions in from Joanne at Lava Group. You mentioned following phase 2, you may consider going to an open procurement process. What does this mean? It just means, Joanne, it's a standard, your regular procurement process. Contract goes up in e-tenders and you respond to it. And her second question, within phase 2, does the challenge allow access to patients for clinical trial? This isn't something that we've considered, and in the UK challenges, they haven't set up clinical trials. The companies have organised that themselves. But if you do win through to phase 1 and it is a consideration, we can certainly have an individual discussion with you about that.
I suppose just for companies with Health Innovation Hub Ireland, I mean, there's a possibility of, getting, I suppose, access to maybe pilot or do a focus group with particular groups within the hospital setting as well. So although it's not offering a clinical trial, there is options to actually get feedback from specialists, perhaps on your device and technology. So yeah, you can connect in with us on that. Thanks very much.
Thanks, Aisling. Any other questions?
Could I just add just something from my experience on the Singapore scene where I've been for over 20 years? It's regarded as a national crisis. It's regarded by the government as one of the strategic initiatives to get this level down, and it's far higher than here. Across diabetic amputation, so it's about 1,700 per year. GDM is huge, 25%. It would help if Enterprise Ireland in Singapore, and the people there, got involved with that community, and there may be some innovations, I know there are in fact, that would be of help here instead of reinventing wheels. And you may have something that you can help them on. You've got a community there that's incredibly interested in cooperating internationally, and I think it would help Ireland to cooperate with another small nation state like Singapore. So with Smriti in Singapore, I think you should reach out to her to get involved in that community. I don't think she is at the moment. You should do that.
Great, thanks for that suggestion. Any other questions? Have we tired you out? There's one at the back.
Just Trevor Winkler is my name. I represent two, you might call them media companies, so we have a broader interest in this debate because we're putting technology, audio, 3D, all sorts of technology into high-end museums who are spending a lot of money, and it just strikes us, why aren't we putting this technology into patient education? So I'm just interested in what basic educational materials are in front of you today when you're dealing with the potential diabetic patient? Is it still going to a surgery with GPs and leaflets? Yes. Or is it saying go and have a look at something online?
Yeah, unfortunately, Dr. Google, I suspect, is a big part of where people get their information. There are some excellent health information websites like Mayo Clinic and other, established entities, organizations. But yeah, we have patients waiting in our waiting room. We talk about a lot at our management meetings, and I think it's got better over the years, but they're looking at RTE news.
Yeah, we could have something in front of them in a few weeks. That's why I'll talk to you after. We have a broader interest in this because if we're putting it into $1 million museum, why aren't we doing something on it?
Thank you.
Yeah.
I'd just like to add that there are some patient education programs, but they're not very well funded. They're not, primary care are not referring patients to them. They're free to attend for people with type 2 diabetes. I mean, there's even limited access to education programs for type 1 diabetes. But there are programs out there. They're just not very well funded and not widely used.
And they probably don't have, there is low-cost technology out there that people just don't access.
Yeah.
Any other questions? No? Okay, great. Well, we might close the event, so I just wanted to reiterate my thanks to the clinicians. Thank you, Professor Dunn, Professor Deneen, for giving your time this morning. Thanks to Barry as well from Enterprise Ireland. Thanks to Aisling from the Health Innovation Hub. And thanks for the Galway Tech Centre for hosting. Please stick around, grab one of the scones and treats we have available, and please get talking as well. Like we do want to encourage collaboration in this process. So thank you.